recording.
Welcome to Break Everything. Your host, Lisa L. Levy, will guide you through critical thought conversations and a journey of directed disruption that makes a difference. Experience bold conversations with industry leaders who are willing to challenge the status quo.
Hello and welcome to our first panel conversation in the Break Everything series. What we're doing today is a thought experiment because I've had such fantastic guests who have shared such insightful ideas in their magic wand question that I thought it might be fun to bring a group of them together to spend a little bit more time exploring how might we make some of these ideas real. I'm really grateful today to have three people with me, Dr. Noor Ali, Dr. Paresh Goel, and Kenneth Wright. When we were talking individually, each shared a perspective from their magic wand on what it would mean for patients to have transparency to pricing and to be able to make better informed decision and how and when they procure their services and what it's actually going to cost them to take care of their health. So I've invited these three guests to join me today. Let's invite them into the studio. Hello, thank you all for being here. I didn't do a formal introduction to each of you today because in our individual sessions, I read all of the pertinent background information. But for guests who haven't seen us before, I would like to go around the room and ask each of you to take a couple of minutes and introduce yourselves to the audience, who you are, and really why you do what you do. Noor, would you start us off, please?
Sure. Hi, everyone. Thank you, Lisa, again for this opportunity. I'm really excited and looking forward to this conversation we're going to have. So my name is Noor. I live in Tampa, Florida. I'm a medical doctor by background in internal medicine and general surgery, but my work now is really around advising 1099 professionals on their best choice for private health insurance. And what I really believe in is leveraging the situation that you're in, leveraging our healthcare system to make the best choice and have the best outcome.
Fantastic, Noor. Thank you for that. Paresh?
Yes. Hi, Lisa. Thank you so much for inviting me back. Hi to everyone out there. I'm a board-certified internist and geriatrician by trade. I have a mobile concierge / direct primary care practice here in the Phoenix Metro Valley. I really got into this field because transparency was a big issue, convenience was even a bigger issue, and quality. Those are the three pillars that our practice stands on, and I'm delighted to say that we've really been able to expand here in the Valley and provide patients with great quality care.
It's fantastic. Thank you. Kenneth, would you introduce yourself to everybody, please?
Sure, I will. First of all, again, like everyone said, thank you. And we're looking forward to this discussion. My name is Kenneth Wright. I am the health insurance savant, and I specialize in coverage for individuals and small businesses. And Lisa asked why we do what we do. Coming from a health and wellness background, I spent a lot of time in the corporate world, working with individual doctors, working with people that were corporate employees. And what I found a continual problem they had was understanding their health coverage and finding out where they needed to go and what it was going to cost them. So that's a role I love playing as a health insurance savant.
Fantastic. So everybody is aware, right? The magic wand moment that we all talk about is an opportunity that I share with the guests to remove all constraints, time, cost, the bureaucracy of the world around us, and create one moment, that one thing that each guest would do to make the healthcare environment better. And with this group of people, transparency was a theme that sort of pulled through each of their magic wands, or at least influenced it. So I wanted to bring this group together to explore it a little bit deeper. With my consulting clients, I would call this an ideation experiment. For us, it's really just an opportunity to lead with an innovative idea, to have a fun conversation where we can break limiting beliefs and explore what might sound crazy to others so that we could actually put the potential of something better out into the future. Our goal today is not to holistically solve the problem of transparency. It's bigger than we can accomplish in 30 minutes. But I think that in 30 minutes, we can come up with something that might be interesting to pursue in other mechanisms. So I'm going to open it up to the floor, and anybody who wants to jump in first with pricing transparency and in healthcare. What does that mean, and what should it mean for our patients?
Well, I'm going to start off with some really, really good news regarding price transparency. I'm sure the panelists all understands that in January of last year, Congress passed the hospital price transparency rule, which required all hospitals to provide information on their costs. As of right now, we're a little bit behind. We only have 14% of all hospitals having participated, but there is some information out there. And then just July of this year, just recently, the Transparency and Coverage Final Rule was passed, which requires all insurance companies to communicate what they're paying their doctors and what they've negotiated as prices. So what we're asking for is right now something that everyone's asking for. The problem with the Transparency and Coverage Final Rule is that the information is being provided in a format that's not understandable by many consumers. But there are some private companies out there, one of which is Turquoise Health, that's analyzing this information and is making it available. So I really feel good in saying that we're making strides in that area. And it's just not people in the healthcare industry that's being understood by Congress and by the people that are asking for it to happen.
Noor, jump right in.
Ken, thank you so much for bringing that information to light. It's a huge step. I do agree. But when we get this information, it's transparent. We can see it. But when we see kind of like the billed amounts and what providers are being paid, it's still ludicrous. It's still ludicrous how much services are being billed for to insurance and how little physicians get compensated for the services, I think.
Thank you so much, Noor. That makes complete sense of why I exited the insurance medical practice industry, because I was spending 2/3 of my career with a computer, an EMR, and scratching my head, pulling out my hair, dealing with insurance companies on why they would not provide services and products to my patients who were paying very good money for their, via premiums and their deductibles, and the reimbursement that I was getting was atrocious as well.
And Dr. Goel, I reference, you, since I've learned and read about you from an introduction from Lisa, as well as other physician colleagues of mine who are just not fairly compensated for their time, for their services. They're constantly frustrated, fighting for the right treatment and care for their patients. And, you are very fortunate that you're successful in your practice and you've been able to overcome that and created your own solutions. Many of my physician colleagues have not, and they're stuck in that cycle of frustration and disappointment, with a system that unfortunately, we may not be able to fix in a 30-minute conversation.
But that seems to me to be a whole different conversation than where we started. I mean, price transparency is much different than physician compensation, right?
Correct. Yeah.
It is, but I do think that there's probably a point of correlation and a point of connection, because as the existing space, and I want to pull us out of the existing space and how that compensation, what charges are and what actually payments end up being, I'd like to sort of leave that, because that is a mess. If we didn't have that and we had the ability to serve patients and care for them with the care that they needed, with a physician being able to say, this is the treatment plan, these are the things that we need to do, and here's what it's going to cost. And here's the specialist that you might need, here's the ancillary labs that you might need, the imaging. but we actually had control of that experience for the patient and the pricing at the beginning. What does that look like and feel like? Is it possible?
I think it leans towards empowerment of the patient as a consumer. Um, our pricing is very competitive on a lab imaging front. I think, Lisa, you were a perfect example dealing with getting imaging and seeing the price tag that was associated with it when it bounced back to you via deductible payment. The same, imaging was available for $100 on the free market via cash pricing. Sorry, go ahead.
Yeah, no, so you were being kind, tap dancing around it. I share the story freely, right? A year and a half ago, I went in for a mammogram and they attempted to bill a previous insurance that I no longer have. And so when it was denied and came back to me, right, it was $1,500. And I went, oh my expletive. And Dr. Goel is my physician. And I called and I said, I thought that we had, a cash pay arrangement with the imaging company. And he helped solve the problem because it was a billing issue, but $150 versus $1,500, my mind was blown.
I mean, I have a great example about that. I just had to have an MRI in my knee. Mm-hmm. Okay. So one of the things about some of the health plans out there is they do not provide coverage for things like MRIs until you meet your deductible. And even then, it might be a percentage of whatever the fee is. There are businesses out there, and I found this one just by looking for it for myself, which is this business called Affordable Scan. And they are located out of Los Angeles. And they found me an MRI on my knee in Miami for $250. Again, an MRI that would usually cost $1,000 to $1,500. So there are organizations out there that are trying to provide cash solutions to people, but a lot of people don't have that $250. They don't have that $300. They really do rely upon their health coverage. And right now, the average health plan's deductible is over $5,000. So again, that's kind of a different issue, but that really doesn't matter if it's transparent or not. If it's going to cost you that much money and you can't afford it, then that's the problem.
Well, I'm sorry, Dr. Goel, you actually wanted to speak
Dr.
first.
Ali, please.
Yeah, I think it's a continuation of the same conversation, same continuum, really. The question really is, well, why is it costing $1,500 in the first place if you can access the same services for a fraction of that cost? And why is that not more readily accessible? Ken, you're resourceful. You are in the industry as a professional. You're able to seek out that resource. But what about a person who doesn't really know where to go and how to start? And why is that disparity there in the first place?
Yeah, I think I have 2 pointers regarding all of this in a global sense. One is medical practices live by very small margins in the insurance-based practice. 60 cents of every dollar is usually the maximum of what a medical practice physician can earn, because 40 cents is carved right out dealing with prior auths, having the staff available to allocate and to do this work. When you look back on what allowables are for insurance companies, this is where I think there's a huge stark difference about what's considered reasonable and what isn't. When, just above 50% is what a doctor can hope to make based on the volume of patients that they're seeing, it becomes one of those things where you are increasing volume to stay up, because rate of inflation versus the Medicare formula that Congress uses to pay us is ever depreciating. So number one, doctors are just seeing more and more patients. That's why when you go in, you get the 5 or 10 minutes, and there's 3 or 4 other patients in waiting room, in examination rooms waiting. That's one fact. The second fact is with this billing portion, now you look at it and say, well, yeah, they billed at an allowable rate or above the allowable rate, and the insurance company just looked at it and said, well, this is what our allowable is, and this is what we're gonna transfer to the patient via deductible. Unfortunately, those limits are so exorbitantly high, because Medicare pays 80% of allowable, right? And the whole insurance structure is based on what Medicare is willing to pay.
Mhm.
And when you try to dissect why all of this is going on, you really, Kenneth, I think you really have to look at why the system's broken and why there's this Medicare formula with a depreciative value that's inverse to the rate of inflation. I mean, most doctors' practices close up shop because they just can't afford to stay open anymore. Everyone, I think, has this mentality that doctors are, living in this lavish palace on the golf course, not seeing patients. We, I work about 80 hours a week minimum, which is double
How
the.
close are you to the golf course?
I live in Scottsdale, so there's 350 plus golf courses here. I'm pretty sure I could throw a stone with the closest one. But the last time I went to a golf course was over a year ago, so it was for a charity event that I sponsored.
Right. We're doing a great job exploring the challenges that exist in our reality today. I want to try and turn our thinking in a different direction. I want to create a bubble around this conversation and leave everything that we've just talked about, the pain points of today, to the side and say, if we had a blank slate, green field, we know that human beings require medical care. How do we build this better? We don't have to worry about CMS. We don't have to worry, insurance, I think, is part of the equation, but what type of insurance? And we've had conversations, and Kenneth, you did the best job for me, right? Insurance, for car insurance versus a car maintenance plan. And how in the health insurance world, our insurance versus health maintenance, we've sort of confused those ideas, and our expectations as consumers has muddled that. If we leave everything blank and we get to start over, how do we start building for an experience with our patients where they are getting the care that they need, they understand what the pricing is? Where would you start? Nora, I'm going to pick on you first.
Did Ken have something to say?
No,
I'm
go
sorry.
ahead. Go ahead.
Okay.
I'll do it later.
Okay.
Sorry,
Well,
I didn't see you.
No, that's okay. Well, I'd like to frame this conversation first with a challenge that I know Ken and I, being insurance professionals, we face a lot, which is kind of a fusion model, which I would love to see, again, that magic wand, where we get that direct quality patient care that Dr. Goel provides to his patients and clients. But the missing piece that when people come to Ken and I is, well, our healthcare system doesn't align for that emergency or catastrophic piece of it, right? Where do we go for a max out of pocket or a stop loss, because medical bankruptcy is the real concern? And that's where there's a misalignment with quality of care and our existing system. So I'd love to frame this conversation with what are some magic wand solutions we can have around that, where we have a fusion of Dr. Goel's services while still solving for that max out of pocket piece, because we have these extremely absurd high billable amounts.
Yeah, Noor, thank you so much. Yeah, that makes a lot of sense, and I think it resonates with what Kenneth had, what Lisa had said, that Kenneth had reverberated, and that's the fact of this catastrophic piece. Everyone uses their healthcare insurance card like a credit card. It's this, I feel like this brainwashing, and the system as a whole has generated this mindset that, hey, if you're not feeling well, go to the doctor, use this card. Go to the pharmacy, use this card. Go to the imaging lab place, use this card. Go to the hospital, use this card. Anywhere you're going, you're using this health insurance card like a credit card. And insurance, the thought of insurance when you have a homeowner's policy, a car, auto insurance is for a rainy day. God forbid I get in an accident. There's a tornado that rips through my neighborhood and takes the roof of my house off, that I have this insurance to cover for such exorbitant amounts of costs. When you go to primary care and for health maintenance, there's this thought that you can use this card, but in reality, cash pricing is so competitive that you can pay with your own regular credit card, or even better, an HSA card, which is pre-tax dollars. So you're lopping that off your gross income and not paying tax on that at all, and it grows, with interest over time. You can use that. I think that is what people should be really looking at, is carving out the primary care portion, having a high deductible plan with an HSA card that covers for the catastrophic. And I do believe there's plans out there that do that, just not the big ones.
That kind of goes back to what part of the issue is I've been alive long enough to remember when every health plan was an indemnity plan, and every health plan was 80-20, right, with a deductible. So you paid the insurance paid 80%, and you paid the 20% difference. Doctors love that, right? The consumer really didn't like it, but that was what was there. It was when they started with managed care, and that goes back to Dr. Gold's concept. Managed care gave people the idea of copays, so that's all they had to pay to go see a doctor. So why not go see a doctor as many times as I can, right? You want people to see the doctor, right? But yet you want them to see it really when it's important. Things like virtual medicine has helped somewhat with that. And I want to go again to Dr. Gold's concept. I'm going to introduce a new product maybe to everyone on this call, which is there's a product out there called a health matching account. Okay. And what the health matching account does exactly what Dr. Gold says you want to have done. It allows a dollar for dollar match. So you put in $1, the health matching company matches $1, and after 3 years, your amount in that account will be doubled. If you put in $2,500, you'll have $5,000 in that account. If you've put in $5,000, you'll have $10,000 in that account. That money has to be spent on medical needs. So the idea of having an account like that, so that you can then pay Dr. Gold what he needs to be paid, makes sense, and then use your insurance for the major things that you're never going to afford. I mean, that's a great product out there right now, and it's trying to address some of the issues that Dr. Gold is talking about.
Yeah, I think it stems in a more broad fashion of how economy in the U.S. works. More than 70% of residents in the U.S. live paycheck to paycheck. They use credit cards that are maxed out. They're constantly in debt. My daughter already has a bank account. She already has numerous bank accounts, what I like to call rainy day funds, that get siphoned off my own bank account on a monthly basis and trickled into these other accounts. And I want to teach her how important it is to be fiscally responsible, in that you should always have a rainy day fund. God forbid, accidents happen. Like, I tout, and I'm proud to tout that I have one of the lowest hospitalization rates here in Arizona. Unfortunately, I can't get to zero because appendicitis happens, bladder infections, colon infections, COVID. All these things happen that are out of my control, and patients need to get hospitalized, and that's why accidental health insurance is so important.
Noor, go ahead.
Ken, I just want to honor Ken a little bit for historically kind of bringing us from what we used to have and the evolution and to kind of these new products on the market that are serving needs. So thank you, Ken, for bringing that into light. But I have to disagree with something Dr. Goel said, because I feel like we're all doing our best to take advantage, to recognize what our system is and offer innovative and radical thinking solutions to our clients and to our patients. That's awesome, but I still don't think it's the best solution. And I want to talk a little bit about brainwashing and a little bit more about insurance companies. It's hard to pose insurance as this big adversary. Most of the time it is, but Ken and I are in this industry, so it's hard to speak all bad about it. But I do want to talk about brainwashing in the insurance industry, because what has happened is this example that Dr. Goel posed, this best case scenario of using your services, having a high deductible plan for rainy days, pairing it with an HSA account, which works as a phenomenal investment account. But really what we're doing is we're taking things that already exist and making the best use of it. But what if we didn't? Like, what if we didn't have to do that? In my mind, when I educate or teach about insurance, especially to younger people, I always advise away from a high deductible plan, because you're paying premiums to an insurance company. You have this high deductible and the very limited low risk chance that you do have to be hospitalized. You have this big old high deductible that probably most Americans can't afford. And because they can't afford it, they have to squirrel away their money into HSA accounts and several other savings and investment vehicles, pre-tax dollars, whatever, to pay for that deductible that they can't afford. So in what situation did your insurance step in to really help you? They didn't, which is why you have to strategize and use these strategies that Dr. Goel's patients probably use to maximize and utilize. But what if we didn't have to think that way? What if we could have Dr. Goel's services as a day-to-day managed care and a reasonable health insurance plan with a low premium, low deductible, where we don't need to utilize financial vehicles like HSAs? That's what I would like to see.
Yeah,
which is, I think,
you can't have low premiums and low deductibles. That's
why
really
not?
because
Insurance companies say so. They're not profitable because that's the model.
Yeah. I mean, again, right. If you cut out the insurance company, but the idea is that if you look at any insurance plan, and Dr. Noor, this, which is the lower the premium, the higher the deductible.
I do know this,
premium,
and this is the conversation I'd like to have.
I know you know that, but what I'm saying is they don't do that for fun. They maintain right now, insurance companies the law is they can keep 15% they have to spend 85% of every dollar on care. They can keep 15%. That number maybe, and that was just passed with the Affordable Care Act. It was put into to law. Now maybe you can cut back a couple of percents on that, and that's what all the consolidation of insurance companies. The goal is to try and do that, but that's kind of right now the actuaries are the ones that have figured this stuff out, and I don't know enough about. Well, I can tell you right now a real case, which is I had a daughter who just went through aplastic anemia. She's completely healed. She's completely fine, but we're coming up on $2 million for that. Now, is it really worth $2 million with the treatment she got? I don't know. I mean, I don't know what it costs to do a transplant, and I don't know what it costs to keep the lights on in the hospital. I don't know all those things. But the idea is that those are the things that really, if somebody has to pay a $5,000 deductible or $8,000 deductible for getting that kind of care, I think it's reasonable.
I do too. I think also a component that we have left out is prevention. I think one of the main drivers of why people go to the doctor is illness rather than prevention. Why not prevent disease from even happening in the first place? When we look at what Medicare spends end of life, what they spend through the life of a 65 and above patient, that's when cost is exorbitantly high, and it's in the tens of millions of dollars that they'll spend on one single person. And when you think about it and you say, well, this person never went to the doctor until they got Medicare, until they got sick and needed to go to the doctor. Why not prevent disease from happening in the first place so that you can improve someone's quality of life, they can live longer, and not drain the system?
That's educational, right, Doc? I mean, it really is. Even people that have access to that stuff, they're just not doing it. My mom is 92, right? She goes to the doctor every 6 months, and she has a really good friend who's 80 who hasn't been to the doctor in like 30 years and says to her, "Why are you always going to the doctor? Why are you always going?" My mom says, "I want to make sure I'm okay." And she says, "You don't have to go to the doctor until something's wrong with you." But that's a lot of people's attitude, right?
I think it blends in well with what the insurance companies want happening, because if you have underutilization, that maximizes profits.
Oh, yeah.
Because they've deferred responsibility onto the consumer to spend. And so the mentality is, well, I don't have this money to spend and go see the doctor all the time. Prevention, I'm preventing my wallet from getting sick.
And that's one thing that Nor and I have. Nor and I have a couple of products that provide first dollar payment. So there's no copay, there's no deductible. It's a first dollar payment for some basic things that people need, like doctor visits, like physical exams, a bunch of like mammograms. So the people that buy this one product can go to the doctor without worrying about their initial cost.
Yeah, I would love to meet both of you guys, in private, so that I can pick your brain and get more information regarding what's out there. I already deal with a couple of insurance agents that have enlightened me on what plans are out there, and there are ACA compliant plans that carve out what I do at a primary care level. I think going to the marketplace is usually the number one mistake people can make. The premiums that are associated with those plans are exorbitantly high. They're high deductible plans, and truth be told, no doctor takes those plans.
That's the kicker. That's the main point. I wanted to mention something, but I think I lost my thought. It was something about, I think what I would like to see, like my vision, Lisa, and I'll share this because I feel like that's the theme of everything here, that magic wand theme, is more of that profit sharing spread more evenly, making, yes, of course, I understand that in our economy, insurance companies have to be profitable, but I'd love to see my physician colleagues be more profitable. I'd love to see my insurance colleagues be more profitable. I just like to see a little bit more that spread more evenly, and that does start with cost transparency.
It does,
Noor, thank you for that summary. I'd like to ask, Kenneth and Paresh to kind of do your sort of close on the thought of the conversation, because this did go in interesting directions.
Well, I'm with what Noor said. I agree completely. I think that once the numbers are out there, the question is, will the people rise up? That's the whole point. Once the numbers are out there and they see that Blue Cross is paying one price for something to a doctor, and that United Healthcare is paying something else for the same thing to that doctor, are they going to say, Blue Cross, how can you screw the doctor like that? Is that what's going to happen? Because if that happens, that's what could change things. People will start making their decisions on really what might be better for their own doctor.
Absolutely. I think, we've already seen the movement from out of network anesthesia groups. The private equity have exited in droves because of this transparency laws. They can't hide behind this opaqueness. And to answer your question, Lisa, and to summarize, I think that the magic wand needs to be multiple magic wands. One is kind of getting over this mindset that the insurance company is your savior. They're not your savior. They're saviors of the board and for the CEO to maximize profits and to delight their shareholders. And that's why when you look at what salaries are for these CEOs for insurance companies, it kind of makes you balk that, well, that's where my money's going.
And the CEOs at hospitals.
Correct.
Yeah, absolutely. This was an interesting conversation, right? The idea of stepping away from everything we know and that we live in is challenging, and it's really hard to do because healthcare is complex, and the layers and the levels that we have to set to the side to reimagine and reinvent the future is very difficult to do. But in this conversation, I think we had some great conversation around some of those challenges in terms of how and when we use insurance and when that best point is and what the best model might be. And there isn't one answer, right? Different people are going to have very different needs. How we actually empower our physicians to provide quality care is another part of that, being able to do a treatment plan that is unique to that individual patient and not just dictated by what is allowed by the insurance coverage, was a theme that we didn't touch, but it was in there. And we didn't necessarily say it explicitly. The idea of insurance being a credit card and how we use it, taking control back and being fiscally responsible as the consumer, the individual patient. There's a lot of complexity here. But I think change begins with conversations like we've had today. And we don't all have to agree because there is not one right answer. And I appreciate Noor, Paresh, Kenneth, thank you for sharing your perspectives and opening up this dialogue, because nothing will change if these conversations don't happen. If we aren't willing to challenge the status quo will continue. So today, this was our first experiment in a panel conversation in the Break Everything umbrella. I appreciate you all for joining me, and I look forward to our continuing conversations. That's it for today.
Thank you for allowing this, Lisa.
Absolutely.
You have just experienced Break Everything with Lisa L. Levy. Critical conversations on directed disruption that makes a difference.